Hello everyone, this presentation will be about normal growth and the factors which affect growth. The presentation was made by the Indian Academy of Paediatricians and is widely available in the internet. I'll be using this as rough guidelines to explain this concept. Many times when people do talk about how similar pediatrics and medicine is, as much as there are similarities, growth is something which is a very unique topic to pediatrics and is essential to understand the art and science of pediatrics in itself. With our introduction, we know that growth is nothing but the net increase in the size or in the mass of tissues, which is largely because of multiplication of cells and increase in the intracellular substance, whereas development is because of maturation of functions associated with the maturation and myelination of the nervous system. So, growth and development are not to be used interchangeably. If we consider the significance of growth is an indicator of the overall well-being of the child. It is a reflection of the nation's economic as well as the strength of the public health system of a particular country. And growth is an essential feature that distinguishes a child from an adult. So, growth is something which is very important in distinguishing a child from an adult. If we consider the factors which affect growth, we classify it broadly into prenatal and postnatal. Prenatally, there are fetal, placental as well as maternal factors. Postnatally, we can consider genetic as well as environmental factors to see what affects growth in itself. Prenatally, if we see, genetic potential is determined by the parental trait. Tall parents do tend to have tall children, and the head size, macrosomia, is common in families. Microsomia is also common in families. It runs in families. It is a purely genetic trait. Mid-parental height can be established in terms of mother's height plus father's height plus minus 13 whole divided by 2. Plus 13 by 2 if it is a male child, minus 13 by 2 if it is a female child. Generally, boys do tend to be larger than girls, and racial factors do vary in the overall growth in different regions. If you consider the fetal factors, there are certain factors which help in promotion of growth and certain factors which help in the inhibition. The factors which promote growth include insulin-like growth factor IGF-1 and 2, epidermal growth factors, TGF-alpha, platelet-derived growth factors, and fibroblasts. The growth inhibiting factors include TGF-beta, Mullerian inhibiting substance, that is anti-Mullerian hormone, and inhibin. If you consider the fetal hormones, it has a more predominant role in the later half of gestation towards term. Insulin and thyroxine both are important for tissue differentiation, and glucocorticoids are essential for maturation of vital organs like the livers and more specifically to the lungs. It is important to note that the influence of growth hormone on fetal growth is very minimal as compared to postnatally. If you consider the placental factors, the placenta, as we all know, is a source for nutrition to the fetus. Fetal nutrition is enhanced by increased villus surface area, decreased diffusion distance, increased dilatation of fetal capillaries, and decreased resistance of the vasculature. If you consider maternal factors, all factors which can possibly affect the mother do in turn affect the growth of the child. Poor nutrition, anemia, recent pregnancies, multiple pregnancies within a short span, high parity, high obstetric score, intake of tobacco, drugs or alcohol, pregnancy-induced hypertension, and other chronic diseases including torch infections all affect the prenatal growth. This flowchart is basically a summary which shows that growth is affected by insulin like growth factor 1 and growth hormone, all these three together. And there is normal glucose transport within the muscle and within the brain. If you consider a gender-wise variation, boys do tend to have a larger growth potential than girls. Girls have an early pubertal height spurt than boys, and the pubertal height gain is more in boys as and when it does appear, which you can see in this chart. Basically, this chart depicts a height velocity. Initially, it is high. The trajectory is more or less similar between boys and girls. At one point, girls do overtake, but when boys do overtake subsequently, it is substantially higher. As you can see, the initial spurt is more for girls, but when the spurt occurs for boys, it spurts even more. If you consider the genetic factors, chromosomal defects are responsible for either short or tall stature. Short stature is seen in Down syndrome as well as Turner syndrome, to name just a few. Tall stature is characteristically seen in Klinefelter's Marfan syndrome. And if you do consider gene mutations, Prader-Willi and Noonan syndrome are also causes of short stature. Marfan syndrome is specifically due to a mutation in the gene. Considering the environmental factors, nutrition is an important causative factor for affecting growth, specifically macro as well as micronutrient deficiency. Micronutrients namely iron, iodine, calcium, zinc, vitamin A and vitamin D. Vitamin A and D being fat-soluble vitamins, which I have explained separately in a different presentation. If you consider infections, recurrent diarrheas, recurrent respiratory tract infections, TB, HIV, malaria, all of which do contribute to a stunting of growth, along with other toxins as well as the food in the environment. Hormonal factors, of course, growth hormone deficiency is an obvious source for affecting growth, along with hypothyroidism and growth hormone resistance. Social factors, namely being a poor socioeconomic status, poor diet, recurrent infections, relatively hot and humid climate, poor emotional response, or a broken family, cultural and religious factors also do play a role overall in growth. As a result of poor fetal growth, if you do consider Barker's hypothesis, there is alteration in the endocrine status which results in programming. This results in structural, physiological, metabolic changes. And in long term, if you do see, studies have showed that IUGR infants are at a greater risk of diabetes, they're at a higher risk of hypertension and hyperlipidemia later on in life. Now, if you consider the laws of growth, it sounds complicated, but it is rather simple. The first thing what we should understand, growth is a continuous process and growth is an orderly process. And the rate of growth is not uniform in all. There are certain times in which the growth is accelerated in certain domains. There are times in which the growth is decelerated in certain domains, and there are certain times where the growth is steady. So you do have a factor of all three. Coming to the acceleration is nothing but an increased growth rate which is seen in the first half of gestation and in the first year of life as well as in puberty. Decelerations are seen in the second year of life to try and compensate and slow down, whereas a steady rate of growth is seen between 6 to 9 years of age, as seen in this chart. If you consider the Calvert's model for attaining height, in infants, it tend to start and fall off by age 3 to 4 years, and overall height gain is 45%. In childhood, it begins at the end of the first year of life and continues up to mature height, so the average total height gain is 47%, and 8% of height is gained during puberty. This is called the ICP or the Calvert's model, as you can see in this chart. If you consider the predominant control in each phase, if you consider infancy, nutrition, and nutrition, which is why it has been highlighted in the slide, I will highlight it once more. Nutrition plays an important role within the first year of life. During childhood, it is the growth hormone and thyroxine which plays a vital role in ensuring growth, and during puberty, it is the sex steroids as well as the growth hormone which helps in the pubertal growth spurt. Coming to the second law of growth, the growth pattern of each individual is unique, and it is important to remember that growth happens cephalocaudally and distal to proximally. I repeat it, growth is individualized and is unique. Growth occurs cephalocaudally and distal to proximally. It's important to note that different tissues of the body grow at different rates, and generalized growth is rapid in the initial fetal life, rapid in the first 2 years, and at puberty. Brain growth is maximum within the first year of life, and is maximum brain and head growth is during the late fetal life and early postnatal life as well. At birth, it's important to note 70% of the brain growth is completed and 90% of growth is completed during adulthood. I'll just zoom in on this chart to explain it because overall it depicts growth in a similar and simple manner. If you consider general growth, it is maximum in the first 2 years of life. There is a quick spurt followed by a somewhat steady phase, and in general is increased during puberty, before which it plateaus. So the first curve what I have shown is a general growth curve. This is not showing any sex variation, it is just a general curve to understand the concept. Initially it is fast, followed by somewhat steady, and a sudden spurt at puberty before plateauing. Secondly, if we consider the growth of the brain and the head, it is maximum initially, followed by which it plateaus. So 70% occurs within the first 1 year, and the balance occurs in slow duration. Thirdly, if we consider the lymphoid tissues, namely the tonsils, lymph nodes, lymphatic vessels, bone marrow, all of which it is somewhat steady. It peaks during late childhood, follows by a dip and a plateau later on. And if you consider the reproductive maturity, it is a minimum up to puberty, and at puberty there is a sudden peak. This chart basically depicts all the different spheres of growth and development. Like I mentioned, lymphoid growth is maximum during mid-childhood to late childhood, 4 to 8 years, where large tonsils and lymph nodes happen. Gonadal growth is maximum at pubescence only. If you consider the period of growth for the terminologies, what we should know, an ovum is there between 0 to first 1 week of life. Post-fertilization, it becomes an embryo. It is called a fetus between 9 weeks up to birth, and a perinatal period is between 23 weeks of gestation to 7 days after birth. There is an update in this. Perinatal period is from 23 weeks onwards. If you consider the postnatal period, neonatal or newborn period is for the first 28 days. An infant is up to the first 1 year of life, followed by which 2 to 3 years of life we can call the child a toddler. School-going child is between 4 to 6 years of age. School-going age is between 7 to 12 years, and adolescence is a time between 10 to 19 years of age. Though the spectrum of pediatrics only covers up to 18 years, by definition adolescence covers from 10 to 19 years of age. Prenatally, if we consider the embryonic period, 2 weeks, you can remember it as 2 for bilaminar, 3 weeks for trilaminar, where heart pumping begins. 4 weeks, the embryo will tend to be 4 centimeters and does take shape as a human with arm and leg buds. Between 5th to 8th week is where maximum development of all the organ systems occur, and this is where the effect of teratogens will be maximum, 5th to 8th week. By 9 weeks, the fetal period begins. Moving on, the genitalia become distinguishable at 10th week, and the lower limit of viability abroad is 20 weeks, 460 grams. Though, for practical purposes, as per Indian guidelines, we do take 24 weeks and 500 grams as the weight of viability. Primitive alveoli and surfactant dust tend to be produced by 23 to 24 weeks. So, based on this, it is understandable that a child which is delivered before 23 weeks is very difficult to survive as a neonate because of the immature alveoli formation and poor lung maturity. The third trimester begins, of course, at the 25th week. By this time, it is expected to cross 900 grams. By 38 weeks of gestation, it is term. Term, of course, is by 37 weeks itself. The weight does tend to triple, and length doubles from that of the 25th week of gestation. So, there is a maximization of the growth. If we consider growth, we need to have various parameters to assess it. The common parameters what we do use are weight, length, height, head circumference, chest circumference, upper segment to lower segment ratio, and arm span. These are the key parameters which we use to measure growth. Collectively, we can label it with one term called anthropometry. So, the term anthropometry comprises of all of these. It is important to remember that we use the term length if the child is less than 2 years or height if the child is more than 2 years of age. Now, coming to the anthropometry of a child which is expected at birth, the normal birth weight is between 2.5 to 3.5 kgs. Normal length which is expected is 50 centimeters. The upper segment lower segment ratio is 1.7:1. It's a ratio. The expected head circumference is 33 to 35 centimeters, and expected chest circumference is 33 centimeters, and as a thumb rule, head circumference is always greater than chest circumference. These are the average growth parameters at birth, the anthropometry of a neonate. If you consider the growth pattern initially, for the first 3 months, baby is expected to grow at the rate of 25 to 30 gram per day, and for 4 months to 1 year at 400 gram per month. 2 years up to the pubertal growth spurt, it is expected to gain 2 to 3 kgs per year. There are various formula to know the weight. A simple formula is age in years plus 4 into 2 is one formula, of course, which is used. If you consider the other formula, up to 2 years of age, it is age in months plus 9 by 2 which will give you the expected weight. This is up to 2 years of age. Age in months plus 9/2 will give you expected weight. I'll just zoom in to ensure there is minimum clutter in the slides. Yeah. Another formula which is used to give weight between 2 years to 8 years of age is nothing but (2x plus 8) will give you the expected weight for 2 to 8 years of age. So a 4-year-old child, if you consider as an example, 2 into 4 is 8, 8 plus 8 is 16 kgs is the expected weight for a 4-year-old. Beyond 8 years of age, a general thumb rule is 7x minus 5 whole divided by 2. So if you consider an 8-year-old child, expected weight would be 8 into 7, 56. 56 minus 5 is 51. 51 by 2 is 25.5 kgs. If you consider the rate of growth postnatally, the important formula to keep in mind is age in years into 6 plus 77. It's also known as Veach's formula. That is a key point in this slide. This table basically shows the height velocity gain. It is maximum during the first 3 months and subsequently goes on decreasing until 2 years of age, at which time it again picks up. So there is a deceleration in the second year of life, like how I was highlighting in the initial slides. This formula is important. I'm highlighting it again. Formula for weight is 6x plus 77 to give the height in centimeters. If you consider adolescence, we can further subclassify adolescence into early, middle and late. Early adolescence up to 13 years of age, middle 14 to 16 and late after 17 years of age. The weight gain in terms of per annum is 2 kgs in early, 3.5 in middle and 1 kg per annum in late adolescence, in which various stages of sexual maturity do occur. The mean pubertal height gain in boys is 27 centimeters and 25 centimeters in girls. And the mean pubertal weight gain is 29 kgs in boys and 24 kgs in girls. So you can remember the rules of 20 here, 24, 25, 27 and 29 as a simple way of recollecting. 24, 25, 27, 29. And if you consider the upper segment to lower segment ratio, like I mentioned, at birth it is 1.7:1 and progressively it goes on decreasing until it reaches adults. The adult expected is 0.9:1 for the ratio between upper segment to lower segment. Like I mentioned, head circumference at birth is 33 to 35 centimeters. In the first 3 months, it grows at the rate of 2 centimeters per month. The next 3 months at 1 centimeter per month. Between 7th to 12th month, it grows at 0.5 centimeters per month. And second year of life, I'm highlighting this, it is 1 centimeter per year in the second year. And greater than 2 years, it is 0.5 centimeters per year. So the maximum rate of growth is seen in the first 3 months, progressively decreases a little bit in the next 3 months, then remains somewhat constant, plateaus in the second year, and then gradually steadily increases. So this is a perfect example showing an acceleration, a deceleration, and a steady state. It is important to note that the adult size head of 52 centimeters is generally attained by 12 years of age. Like I mentioned in the initial slide, head circumference is greater than chest circumference at birth. At 1 year of age, head circumference equals chest circumference, and beyond 1 year, the chest circumference is larger than the head circumference. This is very, very important. Coming to arm span, we all know that the arm span will become equal to the height at 10 years of age, and adults' arm span is 2 centimeters more than that of the height, whereas the height is 2 centimeters more than that of the arm span up to 5 years of age. The skeletal maturation, of course, if you do consider it in detail, preferred estimation is done at the knee and ankle between birth to 3 months of age, 3 to 9 months of age at the shoulder, 1 to 13 years the wrist and the hand is the ideal place to check for the carpal bones, and elbow and hip between 12 to 14 years of age. It is important to remember that there is a steady growth which accelerates during puberty, and this is closely correlating with the sexual maturation. This maturity is often indicated by the epiphyseal closure, and complete skeletal maturation occurs at 22 years in boys and 18 years in girls. If you consider the dentation, there are 20 primary as well as 32 total dentation in a completely developed individual. The approximate number of teeth is given by a simple formula of age in months minus 6. 5 to 8 months is when the central incisors tend to appear, 7 to 11 months by the lateral incisors. The canines between 16 months to 20 months of age, the first molar at 10 months to 16 months, and the second molar between 20 months to 30 months. Moving on to the permanent teeth, the first ones to appear, of course, are the first molars between 6 to 7 years of age, incisors between 6 to 8. The first set of canines, permanent canines, appear between 9 to 12, premolars between 9 to 12 as well, but canines do appear before the premolars. Second and third molars, of course, appear subsequently between 12 to 18 years of age. Now, if we consider a way to standardize all this discussion about growth, the norms of growth are generally represented as tables and charts. These are derived from large cohorts of healthy children in various studies in both cross-sectional and longitudinal manner, and tables are an easy way of studying this. Growth chart is nothing but a graphical manner in which we plot growth as opposed to a variable, that is time. It is superior to tables because early deviations are easily noted. So we'll just take this as a rough growth chart wherein I'm plotting the weight. The red line is what is expected as normal. So as long as growth does continue to appear along the red line, then it indicates that the growth is adequate and height is also adequate. Whereas if I was to say that initially the growth is okay and suddenly there is a plateau, it means that the child was fine and something happened which has stunted in growth. Contrarily, if the growth initially is below the expected deviation, then all of a sudden it does improve because of an intervention. It implies that there has been a successful intervention which has resulted in a better quality of the growth. Height velocity charts are not commonly used in day-to-day practice, but it is important to know the rate of height velocity per unit time, and it indicates the periods of acceleration, deceleration, and steadiness like we saw in the initial few slides. This is most important for identifying growth faltering. Considering distance charts, these are growth parameters which are represented in a graphical manner. Like I mentioned, there are 5 to 7 different percentile curves, namely the 50th percentile, which is considered as average, 15, 10, 5 and 0 on the lower end. In the above side you have 75, 90 and 95. The growth parameters in the growth charts, what we do consider are of course weight for age, which is weight as opposed to the age constant, height or length for age, head circumference for age, weight for length or weight for height, which is considered up to less than 5 years of age. I'll just mark that so that there is clarity. Less than 5 years of age, there we consider weight for length or weight for height, and BMI for age in more than 5 years of age. It is important to note that these are color coded. There are separate charts for boys, which is blue in color, and separate charts for girls, which is pink in color. So like I mentioned, this chart basically considers an 8-year-old boy whose height is 120 centimeters. So at 8 years a vertical line is drawn, at 120 centimeters a horizontal line is drawn, that point is marked. That helps in plotting the height on a growth chart. Now we have different growth charts. One of course is standardized by WHO. This one shows the height for age in girls up to 5 years of age, and the IAP growth chart shows for above 5 years of age. So as a general tendency, we do tend to observe weight for height and weight for height on a WHO growth chart up to 5 years of age, and height, weight and BMI on an IAP growth chart if the child is above 5 years of age, as a general thumb rule. The WHO growth chart, just to know a little bit about it, it's an ideal growth chart that provides data on how the children should grow. It is internationally usable and is a standard. It is a growth reference study from 5 different continents, which was done in US, Brazil, Ghana, Oman, Norway and India. Because it considers various geographical aspects, it is more or less standardized and is considered to be a standard. If you consider the factors which were considered in formulating these growth charts, 4 key factors include ensuring there was exclusive breastfeeding among those children, maintaining a healthy environment, minimal infections and non-smoking mothers as well. Coming to the statistics which were used to describe these growth, normal child of course is considered to be healthy. The median is nothing but the value above and below which 50% of the observations lied. Mode is nothing but the value which is the highest number of observations among the study population. Mean is the average of this population, and z-score or the standard deviation is the extent to which the observed values cluster near the mean. This basically shows a Gaussian curve or a bell curve. It's a symmetrical curve in which it is expected that if we consider a mean and divide it into standard deviations on either side, 50% will lie to the left and 50% will lie to the right side of the curve, which basically means that there is a proportionate amount of population which is below the average and an equal amount which is above average, with majority falling within the average group. If we consider the -2 standard deviation, that is the third percentile, it is considered to be abnormal, and above 97th or above the second standard deviation on the right side is also considered to be abnormal. This is what we call the Gaussian or the bell curve. When I say percentile, taking the example of that same 8-year-old boy who was 120 centimeters in height, he falls for 10th percentile for his age and gender, his height. The implication of that is 10% of the boys are shorter than him at the same age, whereas 90% are taller than this child whom we are considering. That is the implication of percentile. With that example, I conclude this presentation with regard to growth and development. It was a brief presentation which just looked to touch upon the basic concepts. I thank you all for your patient listening, and I thank the Indian Academy of Paediatricians for their continued work in this field, as well as for making these slides available for academic purpose. Thank you one and all.